طيب نبدأ. الصوت كويس؟
أيوة تمام.
تمام. طيب هنبدأ من حيث ما توقفنا. طيب let's take this one here. The image on the left and correspond it to the image on the right. So what do you see here?
Okay, this is a 4-chamber view.
Okay, go. Yeah, whoever ready can take it. So, who is talking? Is my sound clear?
يا دكتور حاتم is clear.
Okay, تمام. يلا حنبدأ الآن. So, who is taking this one? Yes, anybody?
Okay.
تفضل يا
دكتور
معاوية.
حاتم. This is lumbar sternal axis view.
Okay.
Which with color.
Okay.
Which should thicken aortic valve.
Very good.
With a turbulence across the valve.
Very good.
The other view, the LV looks a little bit down. Ejection fraction seems.
Okay.
The L a little bit dilated.
Okay.
For the other view, it is 4-chamber view. Sorry, 5-chamber view.
Okay.
With CW across the aortic valve, which is showing aortic valve velocity. It is more than 4.
More than
4 centimeter per second.
Oh, more than, yeah. It's approaching 6 already.
Yeah.
The maximum is 112. Yeah.
Yes.
So
the max is 5.2. Yes, 5.2.
Yeah, exactly.
So this is going with severe aortic stenosis.
Thank you so much, Maui. I think that's the full description of the two images, and the most important thing what Maui has mentioned is this: the flow acceleration. How the valve looks morphologically is important, okay? But you also don't have to put a lot of weight on the morphology of the valve itself. The morphology of the valve has to match the gradients, and if there is mismatch, you have to sort it out. If the valve is morphologically very stenotic, but the gradient is falling short of mean of 40, then you have to do something. And when the valve looks like pliable, soft, and opening, not so bad, but the gradient is 40 and above mean, then you also have to do something. Any kind of mismatch, you have to sort it out, okay? But the best you can achieve is when the morphology and the gradients are matching. Like in this case, we see that the valve is degenerative calcified with reduced excursion, and like Muawiyah said, the flow acceleration is start at the valve. And this is really important, by the way, لأنه the obstruction might be supra valvular or subvalvular. So where the flow acceleration starts, what you sometimes call it, what you usually call it turbulence, but the right terminology is flow acceleration, not turbulence, okay? The flow acceleration. The flow acceleration here now start immediately after the valve, meaning the problem is here. Now, when we start seeing the flow acceleration below the valve at the LVOT, then we are starting to suspect LVOT obstruction. And if we see it above the valve, it might be supra. Yeah. So the color is a good guide to where the obstruction can be, or is where the obstruction. Okay. So this is also important. Okay. And you also have to be guided by the color to trace the gradient. Like here in the apical 5 chamber, it's open here. Now the jet is going this direction, so you have to put the color on and you trace by the CW, okay? So you don't have to be blinded about the color. You cannot just put the cursor wherever. No, you have to switch on the color and put the cursor where the flow acceleration is seen, and you try as much as possible to come parallel to that aortic stenosis jet. Okay, so now here we have a mean of a mean of definitely more than 40. So this is severe mitral regurgitation. And this is good news because, like Mawiya said, the LV function is reduced, and when the LV function is reduced, that might mitigate the gradient. So you end up having gradients lower than 40 mean, though the stenosis is severe. Okay, and in this case, the way out is what? What's the way out in this scenario? A scenario when you have morphologically stenotic valve with LV dysfunction, but the gradient is less than 40.
Dobutamine stress.
Yeah, here
Echo.
in this case you do the dobutamine stress echo in attempt to activate the contractility and to normalize the flow across the valve and to elicit higher gradient. So if you achieve that, it means you have truly severe aortic stenosis. Okay, but this is important. Okay, طيب. You also have another scenario when the LV function is apparently normal, the contractility is normal, ejection fraction is 60 and above, but the gradient is low, and still the problem is in the flow. That is called paradoxical aortic stenosis, and it is called paradoxical because we assume that the contractility and the flow are synonymous. But now we realize that sometimes you can have good contractility, supernormal contractility, but the flow is low. So that's why they call it paradoxical, because the contractility is normal, but the stroke volume is low. Okay, and in this case, to prove that the morphologically stenotic valve is truly stenotic, though the gradient is low, you have to calculate the stroke volume here at the LVOT. And if the stroke volume here is something lower than 35 ml per meter square, that means you have low flow, normal ejection fraction, and this is paradoxical AS. So paradoxical AS, you have to have two factors: normal ejection fraction, but the stroke volume calculation showed the stroke volume is lower than 35 per meter square. Okay, and in this case you are really stuck because the way forward isn't so we are so at a mess with the paradoxical AS. We don't know the best course of action after paradoxical AS. What are we gonna do with these patients? And there is a lot of controversy in the guidelines, but one way is to go for cardiac CT, for example, and try to calculate the calcium score. You know, this is one of the ways we do now. But usually the paradoxical AS is something of enigmatic part in the guidelines, and so far no clear indications of what to do in terms of diagnostics and therapeutics. Okay, but remember, we have low flow, low ejection fraction, and low flow, normal ejection fraction. So we always have these we have these two scenarios. So the three scenarios you are gonna have with aortic stenosis is normal ejection fraction, normal flow. This is one scenario. Low flow, low ejection fraction, second scenario. Low flow, normal ejection fraction, third scenario. And in each one of these three, you know what to do. In low flow, low ejection fraction, we know we have to do the dobutamine. In ejection fraction, normal flow, normal ejection fraction, That means whatever you get from the gradient, that is truthful gradient and you should trust it. But in case of paradoxical AS, it's low flow, normal ejection fraction. You have to calculate the stroke volume to prove that this is paradoxical aortic stenosis, and cardiac CT for calcium score estimation. Okay. Now we go to the second case, which is probably we stopped here last time. I think this is a case of Hookham, and we stopped here and we said that see the flow acceleration here. It's so different from the flow acceleration we see in the previous image. The flow acceleration starts where? At the LVOT, as you see here. And this indicates that the level of the obstruction is below the valve, and it is clearly below the valve. It's between the septum and the SAM. We are seeing SAM here. You see this valve, anterior leaflet, okay, systolic anterior motion, okay. And sometimes you could also, like in this case, you appreciate that the basal septum is a bit glistening and whitish at the base. And this is called contact lesion. It's due to fibrosis from the persistent slapping of the anterior leaflet on the septum. So you start to appreciate this texture at the basal septum, which is different than the remainder of the septum. And that's because of the mechanical trauma by the SAM on the basal septum. Okay, and here we see the flow acceleration clearly here. We see also posteriorly directed jet of moderate mitral regurgitation. Now I want somebody to describe what is he seeing or is she seeing here on this right image. So what are we seeing here? Anybody?
Okay, the systolic gradient.
This is okay.
Dagger shape indicating
Yes.
osteosis or LVOT
Exactly.
obstruction.
Dagger shaped. This is dagger shaped, which is late peaking of velocity. يعني dagger shape is sort of يعني a descriptive term which is so explanatory, but if we have to describe it in terms of echo language, we are going to say that the signal is showing late peaking velocities. لأنه يعني أنا لما آخذ مثلا the normal fixed stenosis, it's going to be uniform like this one. So the velocities are uniform. But here I'm going to see something like this. So the velocity in the initial jet, these are the velocity, compared to the velocities here are different. So here the velocity has abruptly increased. That's why we call it late peaking velocities. Late peaking, late. But initially the velocity is slow. It's slow. You see the velocity is slow and then it goes fast. So how you describe this one? As late peaking velocities between two brackets, dagger shape. Okay, and you can compare this one to the uniform velocities across the entire spectrum in fixed aortic stenosis. So this indicates dynamic obstruction of the LVOT with Hookham. Okay, so this is the trademark of Hookham. Good. And if I ask you what is the invasive hemodynamic tracing that is equivalent to dagger shape signal?
Spike and dome.
Yes, exactly, the spike and dome. Okay, so the spike and dome is the same mechanism. I'm not gonna elaborate because it will take a lot of time, but it's the same, it's the equivalent. So this is exactly the dagger shape signal in invasive hemodynamics. Okay, now what are we seeing here? We are seeing that they are trying to get a gradient across the aortic valve, and they stop somewhere here. The signal isn't so clear, as you see. You know, the signal is not clear and crisp. The LV looks normal. You agree with me? It's normal contractility, right? Isn't it?
Yes, yes.
Okay, but there is LVH which could be severe. Now, if I stopped here, are you gonna trust this velocity or you are gonna do something better?
We can do Valsalva maneuver.
Valsalva maneuver. Valsalva maneuver is gonna help you if you are dealing with this dynamic obstruction. Like you stopped in this gradient, okay, it's 96 for example. If you do the Valsalva, the gradient is gonna shoot even further to 100 plus. Okay, so you are gonna unmask provocable gradient. So Valsalva can provoke higher gradient only in dynamic obstruction, but in fixed obstruction, regardless of Valsalva, no Valsalva, hemodynamic status, volume status, the gradient remains the same. Okay, that's why it's called fixed stenosis versus dynamic stenosis. So because you know here I'm dealing, actually you see the morphology of, or the contour of the signal is in keeping with fixed stenosis. Don't you agree? It's not dynamic obstruction, right? You see how
Yes.
it looks like? Yeah.
Yes.
But I have one concern about this signal. I really have to know exactly where it starts and where it ends. And
Start very early.
Contamination.
yes, I have to do every effort to know exactly, am I tracing the right signal, or am I being contaminated by MR jet? And that is not uncommon, by the way. Sometimes you move the signal a little bit towards the left atrium and you catch a tail of the mitral regurgitation, and that's gonna contaminate your signal. And we know طبعا the MR velocity is much higher than the aortic velocity, so you might just, instead of having a tracing that ends here, the contamination is gonna take you all the way down to higher velocities. So you have to make sure that you are tracing the right jet, okay, to avoid contamination. And that's why you should always be guided by color, and you try to fine tune and adjust your spectral line, I mean interrogation line, to where the jet is. And we know that aortic stenosis by echo isn't an easy sale, and you always have to do to engage time and effort. What I mean is, you have to interrogate multiple windows, you know, multiple windows, okay? Even you sometimes have to tell the patient to the right side and go for the right parasternal. You have to go suprasternal and stuff like that. You use the pedof probe, the non-imaging probe, and all of that, okay? So that is all because we are trying to find by chance, where the maximum velocity, and we are interrogating that maximum velocity. So our interrogation line is falling parallel to the interrogation, to the jet velocity, or to the jet. But we can't know that illa by a matter of trial and error. Like sometimes you can minimize your trial by into you put the color and try to visualize the jet and how it goes. Is it going eccentric, central, or this time? And you try to modify your image so you bring your interrogation line as parallel, as much as parallel as possible, okay? As I told you, it isn't easy, but you have to make the necessary effort before you close the case, as in you fail to elicit severe gradients. One of the issues about aortic stenosis, if you have been asked, the most important cause of mismatch, clinical and echo mismatch in aortic stenosis, is measurement error. That's the most common, okay? The most common. And that's why you have to go back to echo, do echo again, okay, and try to make reconciliation. Time and effort is always fruitful, okay? That's important in aortic stenosis as in all aspects of echo. Now we go to this case. Now what are we seeing here? So what are
On the left side, there is a power chamber.
Yes, exactly.
With color.
Or chamber with color.
Showing mitral valve thickened.
Yes. Yes.
Mitral stenosis.
Exactly.
On the right side, there is a continuous wave Doppler across the mitral valve. Showing mitral stenosis. Let me to check the numbers. Okay, mitral.
The mean is 12.
Yes, so gradient is 12, and
yeah.
mitral valve area 0.7.
Yes, 0.7 by pressure half time.
Yes.
Okay.
So it is severe mitral stenosis.
Yeah, okay, great for the observation. Actually, I don't know where you find this pressure half time, and I missed it. So pressure half time 0.7, and I mean gradient of 12, and morphologically stenotic valve. And you know, this color is so suggestive of severe aortic stenosis. If I can,
Mitral.
if I can show you here.
Dilated LA.
You see this flow convergence?
Yes.
This is diastolic. Now I'm freezing at diastolic frame. This is a diastolic frame. And you see there is a big hemicircle around the valve. This is PISA. PISA is elicited in MR and in MS as well. So the more flow convergence you see around the orifice, معناتها the more stenosis is expected. Yes, exactly. تمام. Just sometime the flow color itself can give idea about yes, the degree of stenosis. لكن طبعا this is just rough estimation. You cannot rely on that. You have to go precisely by gradients and area. Okay?
Measure.
Yes, exactly.
Planimetry.
And planimetry. Now we have taken this pressure half time as 0.7 in this case. So sorry, pressure half time of 0.7. How do we calculate the pressure half time?
200 pressure half time over 220. 220 over half time.
I asked the wrong question. I'm so sorry for that. I mean the mitral valve area.
Mitral valve area, yes.
The mitral valve area equals 220 over pressure half time. Okay?
Yes.
Yes, 220 over pressure half time. So the pressure half time here, let's find out. Yes, it is 300.
304.
Yeah. So it is 220 over 304, and the answer is 0.72 centimeters square. Okay, so this is the Hadley equation. Hadley, not Hackey. Yeah, so this is the important equation. But there are so many limitations for the mitral valve area by pressure half time. لأنه the pressure half time is basically this one. This is slope. You know, this is slope. So the longer this slope, the more severe the stenosis. The steeper, the less severe. يعني إذا السلوب كان كده مثلا, can if I take this signal, so I have this slope. Sorry. You see this slope? Now if I take another signal which looks like this, the slope will be steeper. So the longer the left atrium takes to empty into the LV, the more severe the stenosis. That is commonsensical, right? It makes a lot of sense. So So the equation is the longer the pressure half time, the more severe the stenosis because the area is tighter.
Yes.
ولكن المشكلة مع pressure half time it is flow dependent, right?
Yes.
It's flow dependent. So it depends on the flow so much. يعني الفلو إذا تغير هنا البريشر half time بيتغير كتير. الحاجة الثانية إنه الفلو also from the left atrium to the LV is affected a lot by the dynamics of the receiving chamber. يعني الآن أنا لو عندي مثلا grade 3-4 diastolic dysfunction which has nothing to do with the mitral stenosis, that is gonna shorten the pressure half time. So the pressure half time is shortened if I have advanced grade of LV diastolic dysfunction.
Non-compliant LV.
Exactly. If I have an ASD for any reason, ASD is gonna shunt a flow away and is gonna shorten the pressure half time. So the pressure half time is affected by so many, factors. لذلك يعني you have to take it with a pinch of salt.
Limitations.
Yes, there are so many limitations. So the gold standard of mitral stenosis evaluation is
Planimetry.
Planimetry. Thank you so much. Planimetry. Just if you just take this one. Just a moment.
حصل شنو؟ أنا ما سامعة. أنتوا سامعين؟
لا قال دقيقة يا دكتور سارة.
أوكي.
يا شباب الشبكة دي كعبة عندي ولا عندكم كلكم كده؟
دكتور حاتم قال دقائق ما كلنا ما سامعين.
ألو شباب ما في صوت ولا أنا بس؟
يا جماعة قال لكم اصبروا دقيقة.
Sorry for the interruption, but I just got an emergency call, that's why. Sorry. Are we back?
Yes.
Yeah, طيب. Now we said that the gold standard of mitral stenosis is the area by planimetry.
Planimetry.
Yes. Now let's take this one. This is again a mitral stenosis case, but the pressure half time again here is suggesting severe mitral stenosis, right? Again,
Yes.
severe mitral stenosis. Now, the planimetry, I wish I have one. No, not here. So I'm gonna just fast forward to where the planimetry is, if you allow me here. Okay. Yes, this one here. This is again a case of mitral stenosis, like you say here. This is the plane in which we measure the mitral valve area, right? Short axis of the mitral valve. But our problem here is that we are so likely to miss the nervous part, because this one here can be, I might be here, or I might be here, or I might be here. Okay? The lower you are, the more likely to strike the nervous part and reflect the truest measurement. The problem is you might be staying above. That's why it's technically not so easy. It isn't so easy, especially if you are just using 2D without any ancillary form of software to help you. But now I think Echo Machine now is equipped with biplane, X-plane. You know this technology, right?
Plane.
Huh? The biplane and the X-plane. So the biplane and X-plane had made it easier for me, because instead of just trying to find out, I'm just seeing here from this image. I'm gonna take you back here. Sorry. Eraser. Pointer. Now, where is the nervous part? The nervous part is here. I'm gonna do this. And click on biplane. I'm gonna have it in the short axis exactly here. Okay? So the X-plane, biplane technology and 3D made it easier for us to cut through the nervous part while we are seeing ourselves doing so. Okay? So this is an important way of assessment of the area to be accurate. Okay? To be accurate. So this is important. Now the other thing is, when we are tracing the area, we also have to trace it in which frame. That's important, you know. يعني sometimes في بعض الناس يفتحوها ليك لحد ما الفالف تلاقيه عمل كده, and they measure it and it is 1.92 point something, and no, you have to know exactly where you should, where you scroll into the area to open it in diastole without missing the valve. لأنه sometimes when you open, this part of the valve will come in view, so the image will move in this direction. So you find suddenly the area has become like this. Okay, so you know where to stop at the nervous part in the diastolic frame. Okay, this is important as well. And then the tracing is just by trace. Okay, you trace it just like that, and you click finish, you get the area. This is so important. Lakin sometimes you have so much of calcification, you don't see, you know, so well which to track and which not. Okay, this is one of the limitations. يعني it's not an easy sale as well. Okay, برضو مرات فيها صعوبات. لكن طبعا definitely is much easier than planimetrizing the aortic valve. لأنه aortic valve is heavily calcified usually, and you lose the tracks. You don't see where the area ends, where it starts. It's difficult, by the way, in aortic stenosis. You can try it, but usually you will fail. Unless you have like bicuspid, maybe yes. Like in degenerative aortic stenosis, it's very hard to planimetrize. Like in mitral stenosis, in most cases, you could manage to have an accurate planimetrized area. Okay? And this reflects the truest degree of stenosis. The gradient is influenced by the hemodynamic conditions, the heart rate, the loading condition, and so يعني الآن أنا مثلا theoretically I can induce a high gradient in a normal mitral valve area. Is that right? Yes, you can. You can. And you can induce a normal gradient in severely stenotic mitral valve. Can you? Yes, you can. So the gradient is so vulnerable to hemodynamic statuses. Therefore, it's not so reliable. لكن الarea remains fixed across the entire spectrum of hemodynamic changes. That's why it's the gold standard. Okay? And طبعا the guidelines, the new guidelines, we are talking about 1.5 and less than 1 or equals to. Less and equals 1.5 and less than 0.5. 1.5 is severe mitral stenosis. Less than 1 is very severe mitral stenosis. So now we have two mitral stenosis which are severe. Severe and very severe according to the area. So, and this is, I think, in the last probably 5 years or so, مش guidelines of 2014. يعني we used to take less than 1 as the cutoff. لكن الآن we are taking less than 1.5. Okay? مش كده ولا انتوا ما ماخذين ال 1.5؟
Yes, agree.
Yeah.
Yes. تمام. طيب. We must go back. Okay. Now, what are we seeing here? So, what do you see?
Okay, so this is we have two views. On the left side, we have modified 4-chamber view with color and without color,
Yes.
which is showing severe MR, which is reaching the posterior roof of the LA.
Okay. Yes. طيب تمام. So, are you confident to call it severe mitral regurgitation based on color flow mapping?
You need more information.
Yeah. The color flow mapping sometimes is dramatically severe and undisputably severe, unequivocally severe, وما في حد can conflict that. لكن sometimes it might look moderate and it is severe. Sometimes it might look severe and it is not really severe. لذلك الcolor mapping itself برضو don't rely heavily on it. You have to have more objective ways of assessment. يعني eyeballing of the jet itself might mislead you. Okay? Remember this one. Why it might mislead you? تذكروا ان احنا قبل كده قلنا what we are seeing here is not the MR. What we are seeing is the MR and the entrainment around the MR. Okay? So if you have central jet, that central jet is more likely to spark secondary jet around it and gets magnified. Okay, while if I have eccentric jet, wall hugging jet going this direction, it might look slim, but it is severe. Okay, yes, exactly. The other thing is that the LA size itself has a lot to do with our eyeballing. يعني الآن عارفين one of the MR that is easily missed ironically easily missed is the MR of papillary muscle rupture. You know, we see it and it is very short, very swift, and not that pronounced. ليه؟ لأنه the left atrium is so compliant, so equalizing the jet fast. So you see, you have to be so careful with the color flow mapping. Okay, you have to be so careful. Okay, you have to go more objective, and objectivity means you have to go for vena contracta,
Quantitative.
for PISA,
And ERO.
for ERO, yes, for volumetric assessment. We have only these three. Okay, vena contracta, semi-quantitative, PISA, and ERO. And the volumetric assessment, the volume of the mitral regurgitation, and the volume fraction. Okay, so these are the volumetric assessment. I'm not gonna discuss them. لكن the only thing is the vena contracta, لأن دي أهم حاجة. Vena contracta more than 0.7 centimeter in mitral regurgitation signifies severe, right?
Yes.
صحيح يا إخوانا?
Yes, yes.
You agree?
Yes, you're
Yes,
right.
agree.
Yeah.
Huh?
Yes, you're right, Dr. Hatim.
Agree.
صوتي؟
Yes, yes. أنت ما سامعنا.
Okay, so 0.7 centimeter and 0.6 centimeter in aortic regurgitation. Okay,
Yes.
Aortic regurgitation.
good.
Yes, it is good. سامعنا.
طيب, now the contour of the mitral regurgitation. Look at this MR. Does the contour tells you anything about severity?
Yes, rounded, dense.
Yes, exactly. طيب, الكونتور الاناليسيس حقه by 3 factors. One is the density of the contour.
Yes.
Okay, 2, the velocity, the peak velocity, 3 is the morphology or the contour.
Triangular.
Now the density, does it tell you anything? هو the more dense, the more likely to be severe, but with a pinch of salt. لأنه
Yes.
density, you know, is not about the severity alone, لكن it's about where you are actually putting your interrogation line. And if it's eccentric and you are here and the jet is going here, you will have faint signal, لكن it's not because it's not severe, it's because you are just missing where the jet is. Okay, and sometimes if you cut sharply through the jet, you will have it so dense and the jet is not that much. So density itself isn't so much reflective of severity. Now the velocity, does it reflect anything about the severity, the peak velocity here?
No.
No, at all.
Yeah.
At all.
Yes.
In fact, if the MR is severe enough, it tends to lower this velocity for 2 reasons. لأنه الvelocity دي is the result of what? The peak velocity is the result of LV, systolic pressure, minus what? Minus what? Minus LA pressure. LA pressure, right? طيب, if the MR is severe, it's gonna affect the LV, leading to LV systolic dysfunction and decreasing this part. And it's gonna elevate the pressure here. So the minus of the 2 is gonna be low. So the peak velocity tends to be lower in severe mitral regurgitation. لكن the correlation is not linear at all. لذلك let's say إنه there is no relationship between the peak velocity and severity of mitral regurgitation. لكن we have a strong and specific correlation between the contour of the signal and severity. So if the signal looks like this one, versus it looks like this one. Okay, this one is severe versus this one. لكن البوزيتيف predictive value is high لكن the negative predictive value is not. معناته شنو الكلام ده؟ معناته if I see a cutoff signal like this one, the positive predictive value of إنه I have severe MR is high. لكن if I don't see it, that is not gonna rule out severe MR. Okay? You get this one?
So it is not
Sorry,
Yes,
I didn't. Sorry, again. If you can come again because I missed your comment. Hello?
Yes.
عندها مشكلة في الشبكة يا دكتور حاتم.
We lost her. I don't know.
We lost her. Okay, تمام معلش. طيب.
عندها مشكلة في الشبكة يا.
Okay, no problem. The same applies to another important measure, which is this one. You see this small hole here? This is what? The left upper pulmonary vein. This one. We interrogate this one by PW when we have for the systolic function analysis and for MR. Usually it looks like this. S, D, and AR. S, D, and AR. This is how it looks like. When I have severe mitral regurgitation, the systolic wave is going below the baseline. So I'm not gonna see it above the baseline, I'm gonna see it below the baseline instead, because the flow is not going in this direction because of the severe MR, it's going in the reverse direction. So that is called systolic reversal in the pulmonary vein, which is specific of severe mitral regurgitation. لكنه again it has high positive predictive value but low negative predictive value. يعني if I see systolic reversal, I am very confident إنه I have severe mitral regurgitation. But if I fail to elicit reversal, that is not gonna rule out severe mitral regurgitation. ليه؟ Simply لأنه الريفرسال هنا is not the function of the severity alone. It might be because of the jet direction. يعني الجت لما يكون eccentric going this way is so unlikely to reach up here. Okay? Again, it's a function of the left atrial volume. يعني if the left atrium is small, the MR is more likely to reach high up here. لكن if the left atrium is so big like this, the MR jet is going to be digested before it reaches the ostia of the pulmonary vein. So it is not ruling out severe mitral regurgitation. لكن إذا لقيته, it rules in severe mitral regurgitation confidently. Okay, so you get these points? Huh?
Yes, yes.
Very good, very good. تمام. Okay, now
Yes, sir.
next, what are we seeing here?
On the left side, there is a Supraspinal.
What is this?
Showing integrate flow in the
Okay.
Supraspinal view
Uh-huh.
with or without color.
Okay.
Flowing gradient systole and diastole.
Okay. طبعا أنا قلت لكم هنا the best description of this one. You are so right when you say suprasternal with and without color, but you can call it supraesternal color compare.
By plane.
Color compare. اسمها
color
color
compare.
compare. لأنه in the if you go back to the echo machine, there is color compare button, right? When you click on color compare, you will have 2D and color side by side. So we better call it, because we are talking echocardiographically, this is called suprasternal color compare view. Okay? لكن if you say yeah 2D with and without color, it's definitely right. It's definitely right. Okay, so now what are we seeing? Are we seeing anything abnormal in the flow here?
There's a turbulence flow in the
Yes,
descending airway.
yes,
It's
exactly.
like coarctation of the aorta.
There is turbulence, and I will like more if you say there is flow acceleration instead of turbulence, okay? So there is flow acceleration in the descending aorta. Okay, now the other image given to you on the right, what does it mean? Huh? Sorry?
High gradient.
Okay, high gradient here. It is 53. Okay, and what else?
Continuous integrated.
Yeah, exactly. So it's not only high gradient like this. If it's like this, I might say, yeah, it's also there is diastolic gradient. So what am I seeing here? What am I seeing here is systolic and diastolic flow on the same direction. So both are forward flow. So we have systolic and diastolic forward flow, and this is coarctation. This is coarctation. Okay, and now this gradient corresponds to the severity of coarctation, right? Right?
Yes.
What else corresponds to the severity of coarctation? What else? This end diastolic velocity. End
This
diastolic
is the
velocity.
systolic flow.
This is so important. Yani if the flow stops here, I might say this is more severe than if it goes here. So the end diastolic velocity might be more specific to severity than the peak gradient. لأنه البيك gradient in particular can be mitigated by what? Tell me. Can be mitigated by what? This peak velocity, peak gradient, by
Collaterals.
thank you so much. By collaterals. Exactly, by collaterals. عشان كده لما يكون في continuous diastolic flow with high end diastolic velocity, this indicates severity even if the gradient is not so high. طيب الآن we have this one. We have coarctation, which is likely severe. What's the next course of action? Intervention?
Measuring the blood pressure.
Measuring the blood pressure, okay.
Yes.
What's it? Okay. And
Abnormality associated with coarctation.
Intervention.
bicuspid aortic valve هل في ولا ما في؟
very good bicuspid aortic valve.
Other congenital malformation like bicuspid aortic valve.
How is the chance of having bicuspid aortic valve here? How high is the chance to find
80%.
bicuspid valve? Huh?
80%.
20 لا أكتر
80 or more.
Yes, 80 or more. لكن if you have bicuspid, the chance of having coarctation is like 30%, right? Yeah. لكن if you have coarctation, the chance of having bicuspid is approaching 80%. طيب, this is right. Now leave echo aside. Apart from echo, what are you gonna do? And clinical data. You have done clinical data, you have done full echo. Next, the patient proves to have severe coarctation.
For indication for intervention.
The patient had severe coarctation by gradients, clinically, and all of that. So what are you going to do next?
CT orthography.
Yes, thank you so much. So another thing which is so important, anatomical data. Now we said clinical data, you were right. Full echo data, you are right. Anatomical data. Somebody might ask, why anatomical data while we have echo which had shown us the anatomy? Echo is not good to show the anatomy here. You see, it's always blind, the spot we don't know, we don't see beyond this one.
To assess the collateral, the presence of the collateral and the degree of it.
Thank you so much. That's why we have to go for anatomical data by CT or MRI. Okay. This one here, after you have the anatomical data, then you can decide whether you are going interventionally or you are going surgically. Okay. لأنه الاناتومي إذا كان discrete stenosis مثلا they might prefer to go interventionally، لكن إذا طلع مثلا long tunnel something kind of and they might prefer to go surgically. Okay, so you have to map out the anatomy. So by echo we have defined the coarctation only functionally, but not anatomically. Anatomically by CT MRI. Okay. Good. Now, what is this? This is zoom in RV apical 4 chamber, and here is the TDI. Where is this TDI sampling, and what does it mean? What are we doing here? What is this TDI? Tissue Doppler imaging of the base of the RV. Here we are cutting through the mitral annulus, lateral tricuspid annulus, and we get this tracing TDI. Does it have any meaning?
The M better flow, passive flow than the active atrial contractor.
Yes, exactly. So this is the systolic flow, and then you will have the E prime and the A prime. So this is E prime, A prime, S prime, just like in the right side, in the left side. Lakin, are we using it for any purpose? For any meaningful purpose in echo? Have you seen this signal ever obtained from the right side? Yes, we do. This is the TDI S prime of the right ventricle for right ventricular systolic assessment. So we are using two signals for right ventricular assessment, the TAPSI and the S prime. طبعا TAPSI is better and more accurate than the S prime. Lakin remember, S prime is also used and a velocity lower than 9.5 centimeter per second indicates impaired RV. Okay, this is the TDI of, and we obtain it from the same location as we obtain TAPSI.
Yes.
The same. You see here. Now this one is 9.1. This is 9.1, indicating what? RV impairment, because we said if it's lower than 9.5 centimeter per second. So this is 9, so it's impaired RV. Okay. Now you see the TAPSI is here. Okay. This is the TAPSI, and TAPSI stands for what? TAPSI stands for what?
Tissue attenuated.
No, tissue attenuation. Tricuspid
annulus.
Annulus plane systolic
Very good. Tricuspid annular plane.
Excrusion.
Plane. Yes. Systolic.
Excursion.
Okay, very good. Excursion. I'm so sorry for the handwriting and all of that. So this is tricuspid annular plane systolic excursion. It is simply the tricuspid annular plane systolic excursion, because this is the tricuspid annular plane, and what we are measuring is the systolic excursion. So we are measuring how much systole does it go high. The systolic excursion means the peak of systole, So we are measuring from the baseline here to the peak of systole here. How much? The distance. That is the TAPSE. So a distance more than 17 millimeter, which is 1.7 centimeter, is normal. Lower than that is abnormal. If you are talking about less than 14 millimeter, that is severe RV dysfunction. Okay, TAPSE is the most accurate way so far and most reproducible way of RV systolic function assessment. اوكي تمام. طبعا قد تكونوا سامعين عن السترين والار في 3 دي يعني كل الحاجات دي يس، لكن الريبروديوسابيلتي حقتها is not as good as TAPSE لحد الان. التابسي has its limitation لكنها so far is the best measurement for RV systolic function. Now, what is this? What here? 62, 61. What is this signal?
This is from tricuspid valve.
Very good. So this is TR signal. And
Yes.
this one is?
This is IVC.
IVC tracing. So
Yes.
from these two signals, I can get an important idea about an important measurement, which is what?
Pulmonary artery pressure.
Okay, and we have to specify that this is pulmonary
Yes,
artery systolic pressure.
Systolic pressure.
Okay, so now tell me how much is the pulmonary artery systolic pressure here?
Yes, 3.5 times 3.5 times 4.
Okay. So you have the pressure
Plus-
already given to you here.
62
So 62, plus
plus the IVC.
how much you are gonna give here? يعني it is dilated and
Not
non-collapsible.
compressed. Not
Okay,
compressed.
so how much you are gonna give? 20.
Yes.
So that is
82.
how much? That will be 82, right? So that is 82 millimeter mercury. Okay.
Yeah.
So yeah, so we have the TR signal from which we get the peak velocity and from which we get the peak gradient. This is one thing we need here. And then from the IVC, we need to have the RA pressure. And this is rough estimation because it depends on how dilated and how collapsible it is. So we are going from less than 5 to more than 20. It depends on what we are seeing here. So the more of the dilatation in the IVC and the less it's collapsible, the more we are gonna go in the high direction. Okay, like الدكتورة مثلا has chosen 20 لأنه the IVC is dilated and non-collapsible. Okay, yeah, يعني if it was not dilated, non-collapsible, I might choose 5. If it's dilated and collapsible, I might choose 10, 15. Okay. If it's not dilated but non-collapsible, I might choose 15. It's stuff like that. It's rough, huh? It's rough estimation. Good. Now, what are we seeing here? طبعا beware of the zoom in images. Zoom in images بتعذب شوية. يعني هسه الآن this one here, this is color compare. From where? Parasternal, long axis RV inflow. Okay? Because this is the tricuspid valve. And we are seeing a pacemaker lead here. That's a pacemaker lead. What else are we seeing in the color? We are seeing what?
Open TR.
TR. How severe is TR here?
Torrential.
Okay, تمام. Torrential or severe. Great. Now we have severe TR here. On here the color, I wouldn't negotiate any further why you think it is severe, because this is dramatic color. And we said that when the you can, it's legitimate to say severe based on dramatic color like this one. لكن لما يكون الأمر يعني somewhere in the middle, you have to be cautious in interpreting the color map. Okay. طيب, now I also gave you this one here. I gave you this. What does this mean here? The image on the right.
Hepatic flow reversal.
Very good, very good. Where is the hepatic flow reversal?
In this mosaic color in the right side.
But I don't see any mosaic color. Maybe a brief
Yeah,
mosaic color here.
Yeah, no, yes, dilated IVC, but there is no.
If I'm gonna stop it here, look here. Sorry.
No.
This is what? This is blue color, right?
Blue?
Okay, now let me see. I wish I'm gonna catch it now. Oh, not yet. Okay. Now you look here. Now I'm seeing red color is sneaking into the hepatic vein. And this at what part of the cardiac cycle? Look at the ECG.
Systolic.
Systolic. Red color means what? A flow going in this direction, right?
Away.
Red color towards, right?
Towards
the probe. Where is my probe? The P here denotes where your probe is.
Yes.
Okay, so the probe is here. So I have color that moves toward the probe. So that is non-physiological flow, right? Well,
yes.
I wouldn't say non-physiological. Like having this much of flow is non-physiological. I have systolic flow reversal in hepatic vein. Systolic flow reversal. Systolic flow reversal. Because I have used the ECG to tell about the time, systolic. And it is flow reversal based on the direction and the color of the jet. So this is a reversal during the systole in the hepatic vein. What does this mean? That means I have a flow that is coming back into the hepatic vein during systole. And the only explanation for this is severe tricuspid regurgitation. So this tricuspid regurgitation is taking all the way back into the SVC, IVC, and then in the hepatic vein. That means it is severe enough to reach the hepatic vein. Okay, so it already fills the right atrium, it spills into the veins, and it goes into the liver. Clinically, you are gonna find a pulsatile liver. So the clinical equivalence of reversal is pulsatile liver, and we know that pulsatile liver means severe TR. Okay, so whenever you find this one and you palpate the liver, you are likely to elicit a pulsatile liver. Okay, so this is important here. Now I'm going to give you the same in PW signal. You look at this one here, this one. How can you interpret this one? Usually the hepatic flow looks like this one. Systolic and systolic reversal. Diastolic and diastolic reversal. You have, this is called systolic forward, diastolic forward, and this is called systolic reversal, and this is called diastolic reversal. Now this systolic reversal is very small and diastolic reversal is very small, but prominently you will have S and D, which are both forward flow. Now if I have severe TR, what I'm gonna find is
Upward systole. So
yes, so the systolic become upward, and I have the D and the diastolic reversal. So what does that mean? It means that instead of forward flow during systole, now I have backward flow into the hepatic vein coming from the severe TR. Coming from the severe TR. Physiologically, the hepatic vein during this time is emptying blood into the right side of the heart. But now, because of the severe TR, the opposite is taking place. Exactly the opposite is taking place. So instead of seeing the forward flow below the baseline, I'm seeing it above the baseline, because now it's coming back instead of going forward. So whenever you find this one, this indicates severe TR confidently. And you remember I have spoken about the pulmonary venous reversal in severe mitral regurgitation, and the caveat. The same applies here. If I see this reversal, I'm confident to diagnose severe TR. Lakin if I don't elicit it, that does not rule out severe TR. Okay?
Because it is very specific but not sensitive.
Yes, thank you so much. So again, we are talking, so the reversals in the pulmonary vein for the MR and in the hepatic vein in the TR are specific but might not be sensitive, and they are great in ruling in severe MR but not in ruling out. They are great in positive predictive value but not in negative predictive value. Okay, so you have to remember this about the reversal. Good. Now, what are we seeing here?
This is wave across the mitral valve. So a variation across the mitral valve.
Okay, variation across the mitral valve. So this one here, you are describing this one. What about the one on the left, this one?
This is precardial effusion.
Atrial fibrillation.
Yes. Precardial effusion.
Precardial effusion. Look for the variation, systolic and diastolic variation.
With a likelihood of RV diastolic collapse. It might
Yes.
not be so clear here, but I always do M mode of the RV free wall to see the diastolic collapse. But it might be here, by the way, okay? So this one is showing large effusion here, okay? And we also have a possibility of RV diastolic collapse. Now we are interrogating the pulmonary, the mitral inflow, and that's what we get. So what we get here, this is, and this one here. This one is expiratory, and this one is inspiratory. So how can I see the difference? The difference is what? Expiratory minus inspiratory over expiratory times 100. I have to get a value, because if this value is more than 35,
40%.
okay, in the mitral, and more than 40 in the tricuspid, that is suggestive of
tamponading.
طيب, are we sure about 35 or it's 25? هي كانت 25.
25 is 25.
Yeah, هي more than 25, لكن usually الآن احنا بقينا واصلين 35 وكده. Okay, so
Okay.
this is important. Now, okay, I want you to have a look in at this one while I'm just answering the phone and coming to you. Probably this will be the last one. So look at it, and we're gonna discuss it now. Okay, what do you think about this? Any description? This is apical 4,
Impressive.
Apical.
and this is apical 3.
3.
It is showing
This is
what?
for
Aneurysmal.
two-dimensional echo showing
Yes, very good.
apical and anterior septum
Yes.
hypokinesia.
Yes, you're right. Very good, very good. So this is important that the anterior septum here is
With
akinetic
aneurysmal apex
with aneurysmal apex.
showing apical and anterior and apical septum and mid septum and lateral wall hypokinesia.
Right. Now you are describing many segments. Let's find out. Okay. Right. Now
With
mid-lateral.
aneurysmal apex.
Yeah. Here, this is the inferior septum. And also here from the mid down, it's akinetic, along with the apex. And here the anterior septum is pairing only this small part. Now we have akinetic anterior septum. So we have wide range of regional wall motion abnormalities. Okay. Good. I might show you the next image. Oh no, not this one. Anyhow, what do you think about this patient? What do you think? Now, if this patient came to the hospital,
Apical and mid
Septal hypertrophy.
lateral and septal wall
septal wall hypertrophy, here, you mean here, huh? In the basal septum. Here, that might not be hypertrophy, but rather hyperdynamic or compensatory hyperkinesis,
Yes.
because this is the only contracting part, so it's trying to
Signal.
compensate. Yeah. Okay. طيب, now this patient came in with decompensated heart failure. Are you gonna take him for cath lab? He wasn't acute. She wasn't acute coronary syndrome. No.
Yes.
Clear outer borders.
No angina, nothing, but just shortness of breath.
Just
and
for risk
decompensation.
stratification.
For risk stratification, like what? Like what? What am I gonna do? What am I gonna do? Coronary angio right away? Or
Not right away.
What am I gonna do before coronary angio, if any?
Stability.
Sorry?
Stabilize the patient.
Oh yes.
Decompensated.
Yeah, exactly. This is so important. Yes, great. This is so important.
Like
Sorry for the bad network.
CT angiography.
Feasible. ما يلدو this حاجة زي
We can do CT angiography.
cardiac is right.
يمكن دكتور حاتم عنده مكان هسه حيجي.
Sorry for the interruption again. I'm so sorry for that. So
No problem.
yeah, so we said risk stratification, and I agree with this risk stratification after clinical stabilization. Now the risk stratification in this case, because we don't know, it looks like ischemic cardiomyopathy, right? Like before diving in coronary angio, I think we have to make sure that we are dealing with a viable myocardium.
Viable,
okay?
yes.
Exactly. So now the next, if I ask you a question in the exam about this cardiomyopathy in a patient who came in with decompensated heart failure, إذا قلت لك البيشنت جا with acute coronary syndrome, that might be different. أو إذا قلت لك البيشنت جا with angina symptoms, it might be different. Okay.
Makes sense.
لكن إذا جا heart failure, that means the chronic repercussion of long-standing ischemic cardiomyopathy, then you have to slow down before going for coronary angiogram. And viability is the best course of action. Okay, and you base the decision for coronary angio on the result of viability. Okay, لأنه هنا في some thinning out, so this thinning out might not be viable, and this patient might not benefit from coronary angio على الإطلاق, وبالتالي just medical therapy. So we shouldn't take this patient to the cath lab على طول. Okay?
Yes.
Okay, now what is this? Okay, we're gonna take this last one. Now this is important. This is very important case for exam. For exam, okay? What are we seeing here? Focus on the one on the left. The most striking abnormality is
second hypertrophy.
Okay.
Second left ventricle.
And
septal hypertrophy.
And what else?
And anterior leaflet of the mitral is touching or obstructing the outflow.
Not really, لأنه if you look at systole during, it's touching during diastole, right? Diastole when it's opening. So it is not SAM. SAM is when the leaflet is closed, لكن it kinks towards the septum. So it's a systolic event. So if you time it here, it's open during diastole and it's closed during systole without touching the septum during systole. So there is no SAM. Like look at this hole here, the black hole. This is the descending aorta. But what is this?
Dilated coronary sinus.
Yes, exactly. So this is dilated coronary sinus. Okay? Causes of dilated coronary sinus. One.
Heart failure.
Heart failure.
Right-sided heart failure.
Unroofed coronary sinus.
Unroofed coronary sinus.
Persistent LVC.
Very good. 3. Persistent left SVC. Persistent left SVC. 4.
Anomalous pulmonary vein derivation.
Okay, I would say coronary sinus fistula. Meaning that it might be the course of the coronary arteries abnormal draining in the coronary sinus and leading to dilatation. Now from this one, the very first one we want to rule out as a reflex is this one. Okay, persistent left SVC, because it's relatively common, right? How many percentage? as far as I remember, it's 5% or something. I'm not so sure. Like in the percentage is really high of persistent left SVC. Okay, so it's common. It's not something rare, you know. Type. Now look at this one here. The same image. Sorry. This one, the same image, but I'm opening the coronary sinus in which view? This is apical 4 chamber. Lakin I'm opening the coronary sinus by anterior tilt. Okay, because I'm going posteriorly. The opposite tilt of opening the aorta. I open the aorta because it's anteriorly in one direction, and I open the coronary sinus in the opposite direction because the coronary sinus is posterior structure. So you can see the coronary sinus and you can see the flow. Now the flow is important for us. Why? Because if it's turbulent or flow acceleration flow, I might suspect fistula, but now it's laminar flow, so I'm not dealing with a fistula. I'm rather dealing with persistent left SVC. So what am I gonna do? A technician comes to you asking of the next step.
Bubble test.
اللي هو agitated saline bubble test. Exactly. لكن where are you gonna put your venous line?
In the left side.
The left. It has to be on the left. Now look at this one. This is what we have done.
Yes.
Okay. So what do you see?
The flow go to the.
Sorry?
The agitated saline being seen in the coronary sinus.
Mm-hmm.
Then in the right side.
Very good. That is very important. So when we give agitated saline in the left cubital fossa vein, we are expecting that this flow is gonna go through the persistent left SVC. This persistent left SVC is draining where? It drains where? It drains in the coronary sinus. So this is left SVC. And the coronary sinus ends where? In the right atrium.
In the right side.
Okay, right atrium. So when you give agitated saline, it will come here, then it will fill the coronary sinus, then it will go to the right atrium. That's an important sequence. We are not gonna see the SVC. We are not seeing it, but we are seeing the coronary sinus and the right atrium or the right side. So the sequence is important. The sequence is important. The sequence here tells us that we are seeing the bubbles where? In the coronary sinus first, then in the right atrium. Look at it again. Okay? Agree? So the bubbles fill the coronary sinus before it fills the right side. And this is persistent left SVC. If I don't have persistent left SVC, how the bubble dynamics will be?
Directly.
No persistent left SVC, meaning that
it will go.
The vein is going here into the SVC, and it goes into the right atrium. So what I'm gonna see? I'm gonna see the bubble in the right atrium with no much of backflow in the coronary sinus. It might spill a little bit in the coronary sinus, or it might not. And even if it spills in the coronary sinus, it will spill later. So I'm gonna see that the right atrium fills first, then the coronary sinus. So the reverse order, exactly the reverse order. So when we give agitated saline, we are not talking about seeing the bubbles here or there. We are talking about sequence, sequence, sequence. So you have to look carefully where the first fills before which. So if the coronary sinus feels first in the right side, this is persistent left SVC. If the right feels before the coronary sinus, that is not persistent left SVC. Okay, good. So this is so important يا جماعة، وأنا أتمنى إنه يعني whenever you are confronted with a dilated coronary sinus like this one, you put color to rule out fistula and then agitated saline. Okay? Good. So I think we are gonna stop here, and we still have a lot to go. So we are gonna make it next session. If you don't mind, tomorrow we're gonna have a session, if that's okay for you. It will not be echo session. Dr. Fahm Al-Kaf is gonna present some MCQs and cases, problems, clinical cases tomorrow. Is tomorrow fine for you? Huh?
Yeah, it's okay, sir.
Tomorrow is fine for you?
Yeah, it's okay.
Okay.
Jama, okay. خلاص, I'm gonna send the link and time.
Yes.
It will be just like 6:30, okay? And we are gonna continue on our echo round this week, okay? I'm also gonna update you. Good? So thank you so much, and see you tomorrow. Thank you. Thank you so much.
شكرا دكتور حاتم، جزاك الله خير.
شكرا لكم جميعا.
Yes, good.